Good morning everyone. Myself Dr. Jeyabalan from the Department of Oral Maxillofacial Pathology. I am an assistant professor from the Vinayaga Mission Sankaracharya Dental College. My topic is on disease of nerves and muscles. So these are the contents today I am going to cover. In disease of nerves, trigeminal neuralgia, Bell's palsy, auriculotemporal syndrome, glossopharyngeal neuralgia, sphenopalatine syndrome, multiple sclerosis, burning mouth syndrome. These are the contents of disease of nerves. As well as in muscles, myasthenia gravis, mild restriction muscular dystrophy, dystrophic myotonia, congenital myotonia, and generalized myoitis ossificans. So coming to the first part of the disease of nerves, this is the trigeminal neuralgia. As everyone know, it is the fifth cranial nerve. It is divided into three branches. Mainly it is ophthalmic, second is maxilla, third is mandible. So as the neuralgia is defined as pain along the distributions of the nerves, therefore trigeminal neuralgia refers to the pain along the distribution of any branch of the trigeminal nerves. Other names is tic-doulourax, trifacial neuralgia, Fothergill's disease. These are the other names. Next comes the disease involving the nerves that supplies the teeth, jaws, face and associated structures. Mainly it affects the second and third branch, that is maxilla and mandible. It exhibits a trigger zone for the pain. The pain is distributed unilaterally for a few seconds to minutes. Etiology is usually the idiopathic condition, but compresses of trigeminal roots by the tumors or vascular anomalies may causes a similar pain. Abnormal vessels, aneurysm, tumors and chronic meningeal inflammations may irritate the trigeminal nerves along the pons. So these are the etiological factors of trigeminal neuralgia. So next comes the clinical features. It is usually affects the older age peoples. Females are most commonly affected, that is the ratio is 3:2. Right side of the face affects more than 1.7:1. Pain is searing, stabbing or lancinating type of pain. Maxillary or mandibular nerve more involved in unilateral, either it is involved in right side or left side. Usually it affects the right side of the face, and females are most commonly affected. The trigger zones are central portions of the face, around nose and the mouth, a nasolabial fold, lips and tongue. These are the site where the trigeminal pain occurs. So coming to the sign of an attack, the patient and the caretaker should know the signs of the attack. The first is physical jerk. Any physical jerk, it causes trigeminal neuralgic pain. Sudden immobility or silence, involuntary facial twinges, a sudden shot out of pain. These are the signs. Next comes the treatment. Coming to the treatment part, carbamazepine, gabapentin, phenytoin, these are administered, and peripheral neurectomy is done. Injection of alcohol, injection of boiling water in the gastrin ganglion, myosurgical decompressions of the trigeminal nerves. Differential diagnosis, first one is migraine, second is post-herpetic neuralgia, next is sinusitis and trigeminal neuritis. Next comes the Bell's palsy. Other names are seventh nerve paralysis or facial paralysis. It is the most common neurological disorders affecting the central nervous system. It is abrupt, isolated peripheral facial nerve paralysis without the detecting any causes. Frequency is more in winter seasons. So as trigeminal nerve, this is also, it is an idiopathic condition. The exposure to the cold is usually causes the Bell's palsy. Local and systemic diseases, possible relations to any trauma, ischemia to the nerve near stylomastoid foramen, any surgical procedures which involves in removal of the parotid gland leads to injury of facial nerves. So coming to the clinical features, it begins abruptly, a paralysis of the facial musculature. It is unilateral. Middle-aged women are commonly affected. Pain occurs particularly within the ears in temporals or mastoid area. Drooping of the corner of the mouth, watering eyes, inability to close the eyes, mask-like appearance on faces. These are the clinical features. As you can see the diagrams, there will be a smooth forehead with no wrinkles, eyelids unable to blink or close. You cannot close the eyes fully. Pain around ears, increasing sensitivity to sound, and mouth drooping, difficulty in eating. These are the clinical features where Bell's palsy patients are facing. So mask-like appearances, difficulty in speech and eating, associated with Merkerson-Rosenthal syndromes. These are the clinical features. Next comes the treatment. No specific treatment for this. Vasodilation like histamine is a beneficial treatment for Bell's palsy. Next comes the auriculotemporal syndrome. Other names are Frey syndrome, gustatory sweatings. It arises due to damage to the auriculotemporal nerve and subsequent reinnervation to sweat glands by parasympathetic salivary fibers. Most commonly it is affected after the surgical procedures of the parotid tumors or any removal of the parotid gland, which involves the ramus of the mandible and has a damage in the auriculotemporal nerves. Next comes the clinical features. As you can see the slide, the flushing or sweating of the involved side chiefly in the temporal region during eating or particularly the spicy food. During eating, the affected person will have gustatory sweating in the parotid region. This effect is called as crocodile tear, where crocodile tears are profusing lacrimation when food is eaten. Follows Bell's palsy, head injury or intracranial operative trauma. To identify this sweating or identify this tears, you must apply an minor starch iodine which is applied on the gustatory part so that you can find the sweating area. Usually starch will changes its color when there is a tear is seen. Coming to the surgery, following injuries to the ninth cranial nerve results in auriculotemporal syndrome, possibly results from parotitis, parotid abscess, parotid tumors and ramus resection treatment. Intracranial division of auriculotemporal nerve. Next comes the glossopharyngeal neuralgia. It occurs in the middle-aged individuals where sharp tooth pain in the ears, pharynx, nasopharynx, tonsils and posterior portions of the tongue. Trigger zone is the posterior oropharynx or tonsilary fossa. It occurs due to swallowing, talking, yawning or coughing. These are the clinical features. Treatment is recessions of the extracranial portions of the nerves or intracranial sectioning. Next comes the Spino-Fallopian syndrome, where the symptoms complex referable to the nasal ganglion or VDN nerve. It may be due to the vasodilations of the internal maxillary arteries, deviation of the nasal septum or septal spur irritating the spinopalatal ganglion. It is like an alarm clock where you get the pain exactly during that time on a day. If a patient is feeling pain at 3 o'clock, tomorrow at the same time he will feel the pain at 3 o'clock. So you call it as alarm clock head pain, usually associated with sneezing and swelling of the nasal mucosa. Coming to the multiple sclerosis, it is also called as disseminated sclerosis. It is an idiopathic inflammatory demyelinating disease of the central nervous system. Patient present with an individual mixture of neuropsychological dysfunction which tends to progress over the years. There is a triad called Charcot's triad where intentional tremor, nystagmus and dysarthria is found in the multiple sclerosis. These are the triads. When patient is affected with multiple sclerosis, these three things will be seen, and Bell's palsy and trigeminal neuralgia can be present. Next comes the burning mouth syndrome. You call it as shortly, we will call it as BMS. Burning mouth syndrome is a chronic pain condition. It is characterized by burning sensation in the mouth without any identifiable media or dental causes. So there will be no dental causes, there will be no ulcer, there will be no any sort of dental causes for the burning sensation, but the patient will feel a burning sensation in his mouth. So there will be no visible oral lesion on examination. The patient may show an increase in thirst, alteration in taste sensation either with a reduction in taste perceptions or the presence of an persistent and unusual taste. So these are the clinical features of burning mouth syndrome. There is no exact treatment for the burning mouth syndrome. So next comes the disease of the muscles. So the disease of the muscles is first and foremost is myasthenia gravis. It is the most commonest disease of the muscles which is affected. The disease characterized by defective neuromuscular transmission, autoimmune diseases that affects the acetylcholine receptors of muscles and fibers and results in an abnormal and progressive fatigue of skeletal muscles. It is most common in females. The repeated muscle contraction lead to less power in contracting muscles. Muscles of mastication and facial expressions are involved. A typical sorrowful appearance of the face is seen. Physostigmine can be used for diagnosis and to improve muscle strength. Next comes the mild restriction muscular dystrophy. It primarily involves faces and shoulders. Myopathic faces weakens of facial muscles. Patient is unable to smile or whistle. Taper lips develops characterized looseness and protrusions. So next is dystrophic myotonia. There is a ptosis of eyelids and atrophy of masseters and sternocleidomastoid muscles. Swan neck appearance is seen. Occasionally myotonia of the muscles and recurrent dislocations of the TMJ, that is temporomandibular joint. Last one is congenital myotonia. Percussion contraction occurs with electrical and physical stimuli to muscles, delay in relaxations of contracted muscles, Herculean appearance due to muscular hypertrophy. Bulking with a strong closure of the eye can produce prolonged contractions of the lids. With this, I conclude my class. Thank you.